Hi, so today I'm here back again with the third part of the series HIV. Today we will proceed with the lab diagnosis. But before that, let's begin with a few questions. So, the first question is the first antigen to rise in blood after HIV infection is? It's the P24 antigen. Okay. Next, the risk of transmission of HIV through needle stick injury is? It's a very important question, and we can give a ratio actually by HBV, HCV, HIV, which is 30%, 3% followed by 0.3%. So the HIV risk is basically 0.3%. Okay. Then the window period for AIDS. I have said it in the last video. You can check it out if you're unable to say it for yourself. And the next one, the P24 antigen is detected by which kind of assay? It's detected by fourth generation ELISA. Okay, so these were the 4 questions. If you're able to answer them, it's very good, but if you're unable to answer them, you should check for the last and the first video as well. I mean the last 2 videos I had posted on the opportunistic infections as well as the disease progression of AIDS, and you will get all your answers. Okay, before beginning with the laboratory diagnosis, let us know something even more interesting about the clinical diagnosis of AIDS. So that is purely based on the clinical features. There are 2 systems for it that are present currently, that is running throughout the world. One is the CDC classification system and another one is the WHO classification system. This CDC classification system has divided the AIDS into clinically 9 stages, and the WHO clinical staging is apparently based on only the clinical features. So one is the CDC classification system and another one is the WHO classification system. So it's not that important to us, but it's interesting to know that AIDS can also be identified clinically. Now let's begin with the laboratory diagnosis. Okay, now going for the laboratory diagnosis, it is entirely different from the bacterial one which we usually learn, where it is followed by sample collection, then direct smear and microscopy, and then it is followed by the culture identification. Here for HIV it's entirely different because of course it's a virus. So and HIV is a very serious infection. For that we need to because there is a chance of being discriminated, we need to maintain its confidentiality. We need to take consent from the patient, whereas he or she wants to do the test or not, and we also need to provide counseling to the patient because of course it's a social taboo. So we need to maintain 3 C's. One is consent, one is confidentiality, and another is counseling. So these are the 3 C's we should follow. Now let's begin first with the screening test. The screening test is the ELISA based test. Okay, the ELISA based test means the antibody detection test. The antibody detection test includes the ELISA methods, and it can be done by the 3 ELISA we have studied from our first year, that is indirect ELISA, direct ELISA, and sandwich ELISA. So these are the tests, and different test kits are available for HIV diagnosis as well. The 3rd generation test kit is present against which the recombinant antigen peptide are used, and anti-HIV antibody are detected in the patient's blood. So what is the 3rd generation kit used for? The 3rd generation kit is used for detecting anti-HIV antibodies in the blood or the serum of the patient. Okay, and the 4th generation now comes to the 4th generation kit. The 4th generation kit is used for detecting HIV antibody as well as what I said yesterday, P24 antigen. So P24 antigen really holds a important value. The HIV antibody is detected by recombinant antigen peptide, and P24 antigen is detected by monoclonal antibody. So HIV antibody is detected by recombinant antigen peptide, P24 antigen is detected by monoclonal antibody. So that is it for the antibody detection. So now we will go for the rapid test. The rapid test give results within 30 minutes and we call it the immunochromatographic test. We call it the ICTs. The first one is the dot blot assay. In the dot blot assay, we perform the tri-dot test. In the ICT, we perform the lateral flow assay. Then we have the dipsticks or the Coombs test and the flow through assay as well. These are the tests that are most commonly used in India. Along with that, we also have the latex agglutination test, but these are also used for detecting the HIV antibodies. Okay. So these were the rapid tests, out of which the dot blot assay, the ICT, the dipsticks are easy as well as important. Remember, the dipsticks is nothing but a kit taken or a identifying card taken, and the serum is added, and then the test is done and checked for the antibodies, and that gives a very quick result of immunochromatographic test. And most commonly they are done for healthcare workers who has suffered a needle stick injury and they need to be given a prophylaxis, so they need to be identified quickly. So this rapid test are usually done for needle stick injuries in case of healthcare workers. Okay, that's it. Now we will go for the supplemental tests. For the supplemental tests, we have the Western blot. First of all, we have the Western blot. The Western blot follows the principle of immunoblot technique. And who recommended it? It was recommended by NACO. Okay. The NACO is the main society who, the NACO is the main organization who decides everything for HIV. So it decided the Western blot as well. So first we had the screening test. Now we have the supplemental test. And what is Western blot doing? It detects antibodies. It detects antibodies against what? It detects antibodies against all the antigenic fragments of HIV. It detects antibody against the GAG gene product, GAG gene product, and antibody to Pol gene product, and antibody to ENV gene product, that is the envelope gene product. We will come to it when we go through the structure of HIV, but it will be clear to you all. But for now, I can explain that Pol gene codes for the three enzymes, that is the RIP enzyme, the reverse transcriptase, the integrase, and the protease. Then the ENV codes for the envelope, that is the capsid and the nucleoprotein, and the GAG gene codes for the GP41 and the GP120. Okay, so this GP41 and GP120 are the antigens, and antibodies are present in the blood. Same for the Pol gene product and same for the ENV. I think it will be more clear to you in the next videos. Next, what happens is antigen antibody complexes form bands on nitrocellulose membrane. Now it's the same process of immunoblotting, where a nitrocellulose paper is used. See, I have drawn here a nitrocellulose paper is present, and the antigen are present in the nitrocellulose paper, and this nitrocellulose paper detects the antibodies against it. I mean, the serum is added to the nitrocellulose membrane, and wherever it gets its required antibody or it performs coagglutination, and we see the band, and according to that we check whether the test result is positive or negative. Now, according to who? That is according to World Health Organization, presence of at least 2 envelope pads, that is GP120 or GP41 or GP160. out of this 3, any 2, either GP120 or GP41 or GP41 or GP160, any is present, which it means the test is positive. Okay, now we are done with the supplemental test and the screening test. We will go for the confirmatory tests. Okay. What falls under the confirmatory test? Our first one is the P24 antigen detection. I already said P24 is very important for us to know. So this antigen becomes detectable after 12 to 26 days of infection. This is the earliest antigen to appear. So it appears in the window period. How long is the window period? 3 to 12 weeks. And P24 appears within 12 to 26 days. Okay, so that's a really faster rate of appearing, and if we detect it in the window period, I think the treatment solution will be better. Okay, after that it disappears and again appears in the late period in the end stage. Okay. Now how do we detect the P24 antigen? The P24 antigen is detected by the ELISA kit. We detect it through the ELISA kit. Which generation? The 4th generation ELISA kit. Okay. I think by now you have learned it that it's by the 4th generation ELISA kit. Okay. Now what is its importance? It has got a lot of importance, and I'm saying it from the very beginning. The first importance is confirmation of HIV. I already said we are learning about the confirmatory test. So this is for the confirmation of HIV. Then for the diagnosis of HIV in the window period, I already said it's 3 to 12 weeks window period. It is appearing 12 to 26 days. So yeah. Then monitoring the disease progress. Okay. That how much the disease is progressed, how they will recover, we can know all that. Then diagnosis of late stage HIV. That because it again appears in the late stages. And also to resolve equivocal western blot. That is, if there is any confusion in the supplementary test, western blot technique, we again confirm it by 4th generation ELISA kit test by detecting the P24 antigen in the blood. Begin with the gold standard test, that is the viral RNA detection, another confirmatory test. Now what do we detect here? The Pol and the ENV genes. Because this is RNA detection, we detect the genes. So it's Pol and ENV genes are the target genes to be detected, and this is the gold standard test. What is it detected by? So this is a RNA detection test, this is a molecular test, and this is a amplification test. You cannot detect this small pieces of RNA in the serum. You definitely need to amplify it. So we are using RT-PCR, we are using real-time RT-PCR, and we are using branch DNA assay. Now what is its importance? Its importance is it's most sensitive and most specific. So both the I's come here. It's most sensitive as well as most specific. Again, we can diagnose it in the window period because obviously the genes do come in the blood in the window period itself. And if we do a PCR, if we perform a PCR, we can detect it. Then it can differentiate between the 2 species of HIV that infects human, HIV-1 and HIV-2. In the first lecture I said. Okay. We also can detect the viral load using the real-time RT-PCR, and we can know about the progression of the disease. Obviously, the viral load will tell us about the progression, how much is the immunosuppression occurred, and how much treatment can be given, and how much the lifespan is. We can all detect by the presence of the viral load, and also we can do the detection of drug resistance genes. So these are the 5 importance, and this is the viral RNA detection that is done within the window period and can give us very quick results. But it's not easy to perform PCR because PCR is costly, it's expensive, it's not available in all the areas of, not even in India. It's in India, it is in present in very posh areas, in the expensive cities and all. So we have developed a easy to perform test that can be done in any parts of India or any rural parts of the world, and that is given by the NACO strategies. Now we will go for the NACO strategies that are present for HIV diagnosis. So what is it saying? In periphery, since Western blot and PCR are costlier tests and available only at limited places, and they are also not very easy to perform obviously. So NACO has formulated a strategic plan for HIV diagnosis. Okay, so now what are its guidelines? Its guidelines are positive result of the first test is confirmed by second and third test. So basically there are 2 to 3 tests that we perform. So the first test result is confirmed by the second and third test. The first test is highly sensitive and the second and third test is highly specific. So the first one is highly sensitive and the second and third test is highly specific for HIV. There are 3 tests, and the 3 tests should be based on different principles or use different antigen. It should not be based on the same principle. And the same kit should not be used again as well. The fourth one is the supplementary or the confirmatory test should only be used when screening test result is indeterminate or intermediate. So what is a supplementary test and a confirmatory test? I think you know by now. The supplemental is the Western blot, and the confirmatory tests include the P24 antigen detection, the RT-PCR as well as the DNA PCR. Okay, next we come for the algorithms. What are the algorithms of the test? Algorithm 1 for screening of blood donors in the blood banks. Algorithm 2A for surveillance in community, and that is called unlinked anonymous testing. Okay, what is it called? Unlinked anonymous testing, that is used for surveillance in community. And next is algorithm 2B for diagnosis in symptomatic individuals, like unexplained diarrhea is present, weakness, nausea, fever, opportunistic infections are present. So that is a symptomatic individual. We are diagnosing it in that patient. We are using the algorithm 2B. Yes. And algorithm 1 for just screening of blood donors in blood banks, so that we do not transfuse the blood with from a HIV infected patient. 2A is for surveillance in a community for epidemiological studies, and 2B is diagnosis in symptomatic individuals, and 3 is diagnosis in asymptomatic individual. Now we will see a little bit about the algorithms in detail. The first algorithm is the one that is used for screening of blood donors in the blood banks. Okay, so here how many test kits do we use? Here we use only one test kit that is used for blood transfusion. So we are using A1. A1 is the test kit. So if A1 is positive, the test is positive. If A1 is negative, the test is negative. Then we go for algorithm 2, where we have two test kits. The first is A1. If the A1 comes negative, the test is negative. We do not do anything more. If A1 is positive, we confirm it by A2. Now A1 is positive. Now we are performing A2. Now if A2 is positive, A1 positive all together, the test is altogether positive. And if A1 is positive but A2 is negative, then the test is negative. Okay. So let us repeat it once more. A1. First we perform the test A1. A1 negative, the test is negative. Done. If A1 is positive, then we go for A2. If A2 is also positive along with A1, the test is positive. The patient is HIV positive. And if A1 is positive but A2 is negative, then the test is entirely negative. Okay. That was about the algorithm 2A. And now we will go for algorithm 2B, where 2 to 3 test kits are required, and that is checked in a symptomatic individual. Here we do the same thing. A1. First we test with A1. If A1 is negative, the test is negative. We do not proceed any longer. If A1 is positive, we go for A2. If A2 is positive, the test is positive. If A2 is negative, then if A1 is positive but A2 is negative, then we have an indeterminate test. We are not sure. So we go for another test kit, that is A3. Now we check it with A3. If A3 is positive, see A1 and A2, A1 is positive, A2 is negative. Now we go for A3. Now if A3 is positive, see all of them are having, all the test results are having different results. So the test result is ambiguous. So we determine as indeterminate. Now we will go for the supplemental or the confirmatory test. Okay. Here this is the indeterminate result. And if A2 is also negative, A3 is also negative, then there was some unambiguity in the A1. So definitely the test is negative. So there is indeterminate and negative test. Now we will go for algorithm 3, that is in the asymptomatic individual. It's almost the same as the symptomatic individual, except that we perform the third test in A1, A2 positive as well as A1 positive, A2 negative. So let us see. Here we use 3 test kits. First we perform with A1. If A1 is negative, the test is negative. Don't do anything more. If A1 is positive, go for A2, same. If A1 and A2 is positive, we were calling it positive in the earlier test. See, it's positive here. But here we go for a third test. Why? Because the person or the patient maybe is asymptomatic. We do not know that even if the 2 tests are telling us positive, whether there is actually HIV or not, because there is no symptoms of the disease, so we go for the third test, A3. If A1, A2, A3 all are positive, then the test is positive, and if A3 is negative, then it is indeterminate. We again go for the confirmatory test. Now if A1 and A1 is positive, A2 is negative, perform A3 with A3. Now if A3 comes out to be positive, because see, there is another ambiguity here, A1 positive, A2 negative, again A3 positive, so it's indeterminate. And if A1 is positive, A2, A3 both are negative, then the individual is of high risk or the individual is of low risk. That depends on further testing. Okay, so this was about the laboratory diagnosis of HIV along with some questions. So we can see here, this were the confirmatory test, this were the NACO strategies, as well as the supplemental test and the screening test. And along with that, we had some questions. So this was a very important part that was covered. Even if you skip everything, you should not skip the lab diagnosis of any chapter. So this was it. Thank you.